In the next half an hour ago, and I think as radiologists, we may not be so concerned with thinking about what tumor heterogeneity is and to what extent it's going to affect the way we look at images presently and in the future. So I'd like to first to start a little bit about talking through the definition of tumor heterogeneity. And very simply put, it's just differences within and between tumors in gene expression, pathophysiology, and molecular features, which are associated with variations in the tumor phenotypes, such as tumor aggressiveness or its sensitivity to treatment. So we can look at tumor heterogeneity on different levels. Clearly, tumors between patients are going to be different. And if you look at a single individual, you will expect the metastases to be somewhat different from the primary tumor. And then you can see differences within the tumor itself. There may be subregions with different cell phenotypes. And even within a certain region of the tumor, there may be different expression of certain features. For example, in this case, KRAS mutation on immunochemistry between the cells. Now, how does this heterogeneity come about? Very simplistically, if you believe that only cancer stem cells can grow into tumors, then you need a large population of different cancer stem cells to result in this level of complexity. More often, what is more widely subscribed now is this idea of clonal evolution that was proposed by Peter and Noel in 1976. And this really was the basis of taking inspiration from the Darwinian selection of how life on Earth arose from a relatively simple organism and then ended up in this complex tree of life that accounts for the variability of the life on Earth. So using this theory, what it means is that you start off with a certain cell that acquires certain mutation, and through time you have cumulative mutation occurring within single cells that then branches off in terms of evolution, and this results in a collection of cells or a tumor that has inherent subclonal population of different complexity. And the contributions to these heterogeneity include, as you have heard earlier from the first two speakers, genetic factors. Epigenetic factors, these are factors that are not really due to gene mutation themselves, but they support the expression of these gene mutations, and also tissue microenvironment changes. So we're really looking about the extracellular matrix, the immunocells, and also the presence or absence of angiogenesis. So I just want to spend a little bit of time talking about understanding genetic mutation. What sort of mutation, when oncologists talk about mutation, and how this affect potentially the complexity of the images and the phenotype that we are dealing with in the end. So there are what are called driver mutations, and these are principal mutations that are necessary for tumor growth. And then there are other sort of mutations called passengers mutations that hitchhike along with the driver mutations. And what is important is that both mutations, when they result, and very much so, that if you look at the cancer as it grows, the cancer life history is very much encrypted in these mutations in tumor. One way of looking at mutational complexity is one hypothesis is the so-called the Transbrun hypothesis, meaning to say that there are different levels of mutation in the tumor. So you have level 1 mutation that is ubiquitous. You think of a tree, and these are mutations that occur in all tumor cells. Level 2 are truncal and branch mutations. They occur a little bit further along on the cancer mutation journey. And then level 3 are potentially 1 and 2 plus other passenger mutations that can, under pressure, becomes primary driver mutations. So one way of, the reason why thinking about this sort of level of mutation is important because level 1 and level 2 mutations are potential drug targets, and these are what companies try to design drugs to target these particular levels of mutational changes. So one way of visualizing this trunch-bunch mutation is that, for example, from moving from left to right, you have increasing what is called mutation complexity. So you think of the palm tree as a really long principal trunk, and then the branches occur really high up in the tree. A bilboa tree has very short trunk, and it's associated with a lot of branches. So what is clear about the complexity of mutation is, as you move from left to right, there is increasing chance of treatment failure. So is there any evidence that the trunk-branch clonal evolution occurs in actually human subjects? And this is a study that was undertaken at our institution, where what was done was that they took repeated biopsies of a renal tumor. You can see the subregion R1, R2 to R8, but also they also sampled two metastases, one perinephric metastases and also a chest wall metastases, and they sequenced the genes to look at the mutation that occurs within these different subregions. So what you see is that the gray areas means that a mutation is present, and the green area mutation being absent. And you can see that there are ubiquitous mutations that occur in all areas of the tumor, and there are areas that are only primarily seen or only seen in the primary tumor, and there are also mutations that are only seen in the metastases, meaning to say that these are acquired through mutation process, and there are other areas that are so-called the private field. And from this, you can construct certain what is called phylogenetic relationship. You can see from normal tissue to renal cell cancer, there is VHL mutation, so on and so forth. And you can see differences, for example, between region 5 and region 4 of the tumor, depending on the expression of the mTOR wild type. So what is the clinical implication of this complexity and this heterogeneity that occurs as a consequence of mutation? Is that if you do a single biopsy, it's really not representative of the entire tumor. Also, there is molecular heterogeneity being present in histologically similar tumors. So this is quite a naive representation. You can see that all these are adenocarcinoma of the breast cancer, of breast cancer, but the different molecular expression of estrogen receptor, progesterone receptor, and HER2 receptors. And what we know now is that depending on the molecular subtype, they're amenable to different sort of treatment. And also, the importance of tumor heterogeneity is that it accounts for cancer progression and resistance to treatment, either due to differential sensitivity of subclones within the tumor cells, or that the chemotherapy may induce mutagenesis, and that leads to tumor resistance. So how are we able to characterize heterogeneity? Well, the most widely used technique at the moment is to do tissue analysis, either by multi-regional sampling or by longitudinal sampling, meaning to say repeated biopsy in a patient, and then you put them through sort of either focus or genome-wide sequencing. And the idea is that if you can better understand the disease phenotype, you can find the best combination of treatment that can target the different subclone population. And this brings us to the concept of precision medicine. The limitations of this approach is that if you're going to do repeated sampling, as we heard, a single sample is not going to be reflective of the heterogeneity. You may not cover the, therefore, you know, and also multiple and sequential biopsies are very invasive. And clearly, if you biopsy the primary disease, it's not going to be representative of the metastatic disease either. So what is the point of thinking using imaging to assess heterogeneity? Well, first of all, it is non-invasive. We are able to look at the imaging of the tumor across different time points. We can look at all disease across the body. We can look at potentially interpatient, intrapatient, or even intra-tumoral differences. This approach can be both qualitative as well as quantitative. And the only downside to this, I suppose, is that we're only able to look at heterogeneity on fairly macroscopic scale. We'll never be able to match our oncologist colleague in the ability to look at intercellular differences. So if we look at just qualitative imaging, can imaging already tell us differences in molecular expression? So we go back to the case of the breast cancer, and we know that triple negative breast cancer, for example, tend to have an enhancing rim on contrast-enhanced images and a cellular rim on diffusion-weighted imaging that reflects the pattern of growth. They often have central necrosis and only left with a cellular rim. And you compare that with the luminal cancers that tend to have a different imaging phenotype. They tend to be much more solid tumors with spiculated edge enhancement. And this is, again, reflected in the underlying tumor histopathology. The qualitative imaging can also alert us to potential differences in the type of tumor that we're dealing with. So, for example, the hepatic stem cell is able to differentiate either into a HCC or a cholangiocarcinoma. And we know that these two tumors have very different imaging manifestation. HCC will typically show early arterial enhancement, followed by contrast washout, and compared with cholangiocarcinoma, that tends to, if anything, show rim enhancement in the arterial phase, but is characterized by delayed progressive enhancement. But then there is an entity, whether you have a cholangiocarcinoma that has contained both elements, and then this results in somewhat of a hybrid feature. And you can see in this example here, you have rim arterial enhancement, there is no washout, and these tumors also characterized by very high FDG uptake, which is atypical of HCC. So again, by looking at the imaging features, we can infer on the potential molecular aberration that is occurring within the tumor. Of course, moving on to quantitative imaging, we can use CT, PET-CT, and MRI to measure different aspects of tumor biology. So we can, on these sort of quantitative imaging technique, provide measurement that reflect the underlying tumor biology. So what sort of information can we gain from quantitative imaging? Well, we go back to diffusion-weighted imaging, and by measuring the apparent diffusion coefficient, we can sometimes get a handle on the underlying biological aggressiveness. So here we have a HCC with different subregions being shown using the red arrow, the green arrow, and the blue arrow. And the area that is highly poorly differentiated shows the lowest ADC value. The moderately differentiated area in blue shows the intermediate ADC value. And the necrosis, or the well-differentiated areas, have the highest ADC value. So that tells us a little bit about potentially what is happening in terms of the underlying tumor differentiation and aggressiveness. Now, what researchers are all really trying to do now, and I heard from Anwar, is that, the idea that tumors are not responsive equally to treatment, and therefore is the result, is the potential cause of treatment failure, is that how do we get a handle early on whether tumors are actually responding or not? So there are various techniques now that we can apply to quantitative imaging that we can begin to unravel the nature of intra and inter-tumoural differences or heterogeneity. We can certainly look at what is called histogram analysis. This is to look at how a particular quantitative parameter is distributed, and there are features that we'll talk through. We can talk through texture analysis, which will look at spatial complexity of the acquired images. And then we can apply what is called cluster analysis technique, where we can characterize tumors using 2 or more quantitative values. So histogram analysis, very simply, when we do a volume of interest over a tumor, we can say, well, we want to look at how all those ADC values are distributed within that volume of interest. And we can then describe a number of parameters, statistical parameters, that relate to that histogram distribution. We can certainly look at the mean and the median. We can also look at a certain threshold value, and this can be arbitrary or based on literature, where we can say that we want to know how many percent of the entire histogram falls within or above or below that threshold. And then we can also look at ADC maximum and minimum value. And the thing to caution here is that if you want to look at ADC minimum value, which has been invoked for quite a while, ADC minimum is unfortunately associated with very poor measurement repeatability. And then we can also look at this parameter called skewness and kurtosis. And skewness is just how the peak of the histogram, whether it leans towards the right or to the left. So towards the right, it has a negative skew, and towards the left, it has a positive skew. And then kurtosis is the roundness of that peak. So something that has a very sharp peak has a higher kurtosis, and something that has a very flat peak, a lower kurtosis value. So the reason why we want to know this sort of features is that when you look at treatment response, for example, using ADC, and when you look at the histogram, you can also see changes in these parameters. So not only do the mean and the median increase as you expect as the cells undergo cell death, there also increase in the number of voxels above 95 centile threshold of the baseline distribution I show you in a minute, and decrease in skewness and kurtosis. So just by way of example, here is a distribution of a tumor before treatment. And here, anything in red is in the higher 95th centile. And initially, you can see very few voxels in that area. And after treatment, you can see the shift of the histogram to the right-hand side. So there's decreased skewness. The peak is rounder, so there's also decreased kurtosis. And then you can see that there are many more voxels now occupying that region that is initially on the 95th centile of the baseline distribution. And can you map these changes back to the original pictures on the original ADC map and see where these changes are occurring in relation to the treatment. So another example here. Here we're only showing you maps. Again, here red, yellow, green. Green is above the 95th centile of the baseline ADC distribution. And here we have a liver tumor that is treated with different anti-angiogenic and antivascular agent. And you can see after antivascular agent, there is some necrosis or very high ADC value occurring within the tumor, but that was quickly reversed. And when you combine antivascular agent with the anti-angiogenic treatment, then you can see that the effects are much more sustained. So what this map tells you is that not only are you able to glean on where not only are you able to tell that the ADC values are changing, but you can also see in relation to the tumor where within the tumor these changes are occurring. So this is intra-tumoural heterogeneity response. Now, if you're able to look at intra-tumoural heterogeneity, you can also look at differences between tumors across the body if you're doing the whole body diffusion-weighted MR imaging technique. And Anwar showed you beautiful pictures of segmented volume, but just imagine for a moment now that you want to extrapolate it and go one step further. You can now begin to color each and individual tumor across the body in a different color. Now, if you're able to do this before and after treatment, then you have a potential to begin to describe how each lesion is going to change with treatment. So here we have, for example, a whole body MRI image. This is pre-treatment, this is post-treatment, and we're looking at the area of the acetabulum and the upper femoral head. And we're looking at the baseline distribution here, so remember everything that's below the 5th centile, we're coloring it red, above the 95th centile, we're coloring it green, and then in between is just blue. And after treatment, you can see that well, there are changes occurring in all three parts of the histogram. So there are certainly more voxels in the upper centile, above the 95th centile, and also more voxels in below the 5th centile. And you can represent this change by looking at this pie chart here, and this, depending on the percentage of these areas, they are represented correspondingly on the pie chart. And you look at the post-treatment changes, you can clearly see that most of the high ADC values are occurring in the femoral head, but the posterior acetabulum is showing a reduction in the ADC value. Now, if we imagine that if we say mathematically that something that is, if you have a dominant group that accounts for the majority of the voxel change, and we, in this case, say it's 70%, and we call that a uniform response. And then within that tumor, if we say that, well, if no component is more than 70%, that is a heterogeneous response. What sort of information would we potentially get? So if we look at across the body, and you can imagine that we now look at a patient and look at each and individual area in the body, we can begin to see how those voxels are changing. Now, the biological implication of that clearly is not clear at the moment, but this is a way potentially that we're able to use this sort of information to get a glean into how heterogeneity is developing as treatment progresses within the cancer patient. Now, this is an interesting histogram analysis, and Anwar alluded to this earlier on, about tracking clonal evolution with treatment. Here we have a patient with ovarian cancer, and she has two solid tumors in the upper abdomen and a cystic tumor in the pelvis. And what was interesting that we were able to do 10 repeated whole body MRI on this patient. And as the treatment progresses, and this was clearly a successful treatment because the tumor markers are falling, we can see that the ADC value actually normalizes, or there is ADC convergence. So that's telling us that actually the therapy is hitting both the solid as well as the cystic tumor. And the cystic tumor is showing some degree of resorption of the fluid, whereas there's actually decrease in cellularity of the solid tumors. So we can track the ADC evolution of treatment with time. Now, moving to texture analysis, well, this is a post-processing technique, and this is something that you probably read a lot in the literature, and what we're looking at is how the voxel signal intensity within the volume of interest is varying, and we can describe certain parameters or what is called first-order statistics parameters that relate to how the voxel intensity is distributed across an image. So what has been clear is that if you read the literature, then there is some compelling evidence that this provides some sort of insight into the tumor behavior. So for example, across different tumor types, people have described different texture being associated with either good or poor patient prognosis. So just let us take an example. This is a publication from a colleague in London, Vicky Goh, where she looked at renal cell carcinoma treated with multi-kinase inhibitor. And if you look at the differences in survival between good and poor responders defined by RISS, Troy criteria or modified Troy criteria, and if you use texture analysis, uniformity in this case, as the predictor, it seems to separate out the two groups of good performance versus poor performance patient better than either size criteria or Troy criteria, which is based on both size and also CT density value. So clearly there is something in it. But what I think is difficult for us to consider texture analysis is that the biological underpinning of this technique is uncertain, because what does entropy really mean in relation to the changes in tumor biology with treatment? There is also a lack of consistency in the reporting of parameters across the different studies. And also, multiple parameters are often tested, so there's a need for robust correction for multiple testings because there's a potential for the so-called type 1 error. Last but not least, I just want to talk about cluster analysis, and what we are doing here is attempting to put together two sort of quantitative measurements so that we create subgroups of a particular biological behavior. So we'll come back to this renal cell cancer, and we are now looking at two parameters, ADC that reflects cellularity, and IAUGC, which is the initial area under the gadolinium curve that reflects tumor vascularity or perfusion. So if you look at IAUGC on the y-axis and ADC on the x-axis, then anything here that looks like high IAUGC, high perfusion, and high cellularity, that is low ADC value, we're looking at here region 1 that's associated with actually quite a lot of high cellularity. I'm sorry, this slide is partially obscuring. So compare that with what you're looking at region 7, where you have very high ADC value and low IAUGC. You're looking at areas with potentially much higher percentage of necrosis. So this is completely understandable. So can we use this sort of cluster analysis to tell us a little bit about heterogeneous response? So here we have a whole body MRI of a patient with, again, prostate cancer treated with a targeted treatment over time. And you can see that superficially the dark areas in the bone appears to be getting lighter with treatment, so there appears to be a response in the bone. But you also see that there is a retroperitoneal soft tissue mass here, as I pointed out to you, that doesn't appear to be changing very much. So what we are able to do is that if you apply this sort of cluster analysis, now, then we are looking at areas, coloring red areas that have very low vascularity and low cellularity. I beg your pardon. Red is the area that had high vascularity and high cellularity, and green areas being of low cellularity and low vascularity. You can see that with treatment, what is happening is that the bones are all responding to treatment, but not the soft tissue disease. So what is interesting here is, although the tumor size hasn't really changed in relationship to treatment, what is clearly changing over time here is that the differential response we've been able to separate this out based on differences in their cellularity and vascular behavior. So is this important? Well, it is, because this paper has just been accepted for publication, and we're now looking at just the RECIST criteria of a patient who has been sequentially followed up on a PARP inhibitor treatment. So in this patient, you can see the peritoneal disease is getting better over time, and that is decreasing in volume, and in fact, there was complete response to the peritoneal disease, but at this point, she developed a new liver metastasis, which was resected. And what we were able to do in this retrospective analysis was that when we look at patients with differential response or without differential response, the patients with differential response had a poorer survival compared with those that did not show a differential response. So in the interest of our time, I'd just like to conclude that tumor heterogeneity arise from clonal evolution, which influences their biological behavior and sensitivity to treatment, and that we can use imaging techniques to capture and reflect this heterogeneity. And that, no doubt, we have to use multiparametric imaging that will be investigated alongside molecular pathology and genomics to improve our understanding of cancer biology and treatment outcomes. So thank you very much for your attention.